Rhonda Pendell Charles, Alderwoman for Ward 3 in the City of Annapolis and host of Watershed Moments. And welcome to our show. Today, I am so very pleased, honored, and privileged to have with us as a guest today, Dr. Jinlene Chan, who's our health officer for our Anne Arundel County Health Department. Welcome, Dr. Chan, to Watershed Moments.
Thank you so much for having me here. I'm really pleased to be here.
So great to have you here. And I think the audience today will learn quite a bit from what you have to tell us today. Let's start with the Jinlene Chan story.
Okay.
And that's from the beginning. And tell us a little bit about yourself in the early years.
Well, I was born in Pennsylvania, and my parents had gotten there because they immigrated from Malaysia and Indonesia, and my dad was going to school at Lehigh University in Bethlehem, Pennsylvania, so that's where I was born. But what I really remember is actually in Myrtle Beach, South Carolina, because that's where my dad got his first job, and so that's where I really remember growing up, because that's how where I went to elementary school, middle, and high school, and those were all of my developmental years. So when people ask where you're from, I'm from Myrtle Beach, South Carolina, and I still go back there every year. So
a lot of people do go every year.
Yes, yes, and I'm very lucky to still have friends and family there. So,
wonderful, wonderful.
So, yes.
All right, so sounds like you had a very diverse childhood, siblings.
Yes, so I have one brother, younger brother, and he also lives in Myrtle Beach working there, and so we're pretty close, and my dad and mom come up and visit quite a bit. I have 3 children. I'm married as well, and so we are very busy here and doing baseball season right now in the spring, so lots of things happening, so I'm very excited.
I remember those days myself. But anyway, so you finished high school in Myrtle Beach, and then you went on to...
So I went to the University of Georgia, and for me that was a big deal because I was going pretty far away, but that was across the border into Georgia. So that was about 5 hours drive, I remember that, and that's where I went to school and decided to go into pre-med, but I also majored in Spanish literature. And so I did a double major in biochemistry and Spanish literature.
Wow.
And I say that that sort of built the foundation of where I am today, because when I graduated college in 1995, I then did, and this is really where I think it shaped my career in public health, I decided to take a year off. I had applied to medical school and I'd gotten in. I knew I was going to the Medical University of South Carolina in Charleston, South Carolina, but I asked them to defer. And they said, okay. And I then did an internship at the Centers for Disease Control and Prevention for 6 months. And then for the other 6 months, I went down to South America and I taught English in Cali, Colombia. So this is in the mid-90s when the cartels were still fairly powerful, although some of the big ones had gone down. So that was a real formative experience for me to go down. And that year, I say, really shaped a lot of where I wanted to go in life, because at that point in time, when I was going into medical school, I knew I wanted to go into medicine. I wanted to help people, right? But that helped me to really see what the role of public health was, and also just the conditions and living conditions in a developing country like Colombia in South America really made me go, I really want to do international health, and that was really where I was headed in health.
So once you got to medical school the next year, you had a great vision of which direction you wanted to go in. So how did that first year in medical school?
It was brutal.
Go.
It was a brutal year. But first year medical school, you don't know what you're doing. You go in and you do the dissection, and you're learning a ton. People talk about kind of opening up the fire hose and trying to put your mouth over it, and it's a lot of information. But it was also a lot of really interesting people, and you learned so much stuff. But really, I think that as you got into and I thought I would go into public health at some point, but there was a lot of people there that were going, you got to go into OB or anesthesia or pediatrics or family practice, and so all of those things were interesting to me as well.
Fine. But that 1 year that you took off to do the 6 months, and the 6 months had to be very instrumental in the direction and how you saw your vision in in the medical school when you got there. So you were probably way ahead of others when you did that. But tell us a little bit more about as you went through your residency and that sort of thing.
So, in medical school, I was doing things like, medical Spanish because I knew how important that was, and that was based on my experience. When I finally decided, look, I'm really interested in public health, and this is ultimately what brought me here to Maryland, is I said I want to do my master's in public health. And, Hopkins, I had actually a couple of other students who I had gone through school with in medical school who came up to Hopkins to do their master's in public health. And I started looking into it, and they're really renowned for the international part of it, of the work and their departments. And I said, that's where I want to be. So I came up after I graduated medical school, and I did my master's in public health. And so I will say that that opened my eyes quite a bit, because in my master's class alone, there were people from 200 plus countries around the world coming from, when you talk about diversity, it is incredible. People who were fresh out of college, people who were ministers of health in their own countries. It was really just an amazing learning experience. Much more than just the classes, but just the people that you were working with and talking through things with. Still keep in touch with a lot of those folks. So really just amazing people. And so at that point I decided, pediatrics is really where I wanted to put my life's work, because, when you talk about prevention and you talk about public health, pediatrics is, the ultimate sign of prevention, because you start out with the pregnancy and creating a healthy pregnancy, and then the children and vaccines, which has made such a huge difference in our country and really around the world in preventing diseases that used to kill people. So polio and measles and, all of those, and chicken pox, used to kill people. And you hardly ever hear about it anymore. So I knew that that's really where I wanted to go. Ultimately, what I did after pediatrics residency was I did another residency in preventive medicine. So it really combined the two, and that's a separate field of medicine as well.
At Hopkins as well?
At Hopkins. And then I had the opportunity to go to Guatemala for 6 months and worked there with the Pan American Health Organization, and also with the Ministry of Health in Guatemala, looking at rotavirus and diarrheal disease and trying to push immunizations, so rubella and measles immunizations down there. So I was really, really fortunate to have that experience, because it not only helped me continue to enhance my fluency in Spanish, but just really gave me a huge appreciation for international health and just the conditions that people work under and the limited resources. So.
Now, you had indicated off the record that your parents were actually from China. So how did that background and familial experience help you as you went along in your health career?
So my parents, so I'm first generation. I was born here, and when I talk about and think about my parents and the educational opportunities that they had, they worked really hard to give me and my brother the chances that we had. And I'm incredibly thankful for that. My dad didn't start school until he was 9 years old because he was working on the family farm, and there were very few educational opportunities for him. And his dad actually didn't want him to go much further than a couple grades, wanted him to come back and work towards, work on the family farm and help the family. And he was not the oldest child of 9, but he was, I think, the second or third oldest. Didn't want him to do that. But he was the first in his family to go to college. And of course the first, and maybe still the first and only, to gain a PhD in solid state physics. Which is what he went to Lehigh University for. So I can't imagine, the courage that it must take to leave not only one's family, but one's entire culture and language to come to another country seeking opportunity. I think that that's something that's so powerful. And my dad, even now when I talk to him, just kind of said, well, I wanted to do it, so I did it, and it's sort of not a big deal. Just sort of, well, I decided to go to the grocery store. I decided to just go to the United States. But you think about that monumental decision because it has impacted, obviously, my life.
Absolutely.
And my children's life, and, for generations to come.
Yes.
And so that split from the family, not, because of any, problems, but just because of a decision he made to better his life and pursue his dream.
Do you have any idea of what gave him the drive, the impetus to do that?
My dad has always been very forward-thinking and also very stubborn in his ways. So, I think that he always had an innate curiosity as well. So I think those combination of all of that really drove him forward and made him pursue something that, nobody else maybe would even dream of. To go from a very poor farmer's boy in Malaysia to achieving, getting entry into one of the top universities in Taiwan, to then a PhD at Lehigh University is really a huge accomplishment.
It is, and that's a huge story in itself.
It is,
Yes.
It is. And so I'm working with him now to try to tell that story. That's important for me and also for my children, and
And it's important for others to hear as
Yes.
well. I mean, it's encouragement for others to hear how people can go from basically very little to great heights.
Right. It does drive me, because I sort of think about, when you look at medical school, which is, a big, it's a big challenge, or residency, and the long hours that one puts in. I think about what my dad must have gone through and his work ethic, and and it's something that continues to drive me even today, because I think about the long hours he worked and, to support his family. He was determined to get ahead and, to make a better life for his family than he had growing up. And that was an important thing for him, and something that he really instilled in my brother and myself. So
now, after your second stint through Hopkins, then what?
So I then looked for and applied for a little job at Anne Arundel County Health Department here in Annapolis, and didn't think it would lead anywhere. And I thought, I'll be there for a few years and move on. And so, and I will say the rest is probably history. But yeah, so now I've been in at the Anne Arundel County Department of Health for a good little while, and so now I'm the health officer, and it's just been a tremendous experience. It's been so rewarding to work with the people that I work with, from the very beginning to now. I think that the spirit of collaboration, the spirit of teamwork, of really truly caring for each other and for the work that we do as a department is something that really inspires me every day. And I just feel incredibly fortunate to work with the people that I do work with. I learn from them each and every day. And even though now I'm the health officer versus, a staff physician previously, I'm just so fortunate to work with them, and they have all taught me something, valuable, and I continue to learn every day. So that's what makes, our job, and also just the work of the department, just such an amazing thing.
Now, how did you get there?
To
the health department? You just applied? Or?
I did apply. So, I had a little experience there working with one of the deputy health officers, Dr. Catherine Farrell.
Oh, I remember
who
Dr.
you might
Farrell.
remember.
Oh, absolutely.
This was under Fran Phillips.
Absolutely.
And so I did a rotation there during my preventive medicine residency, just to gain some experience in local public health. And I will say local public health was not what I was thinking about, because I was still very much focused on international health. And so I was planning to go, travel, work with, the WHO, the World Health Organization, or somebody. And but when local health called, and when you look at local health, and this is what I tell other students now who are really struggling with, well, where do they want to go in public health, because it's such a broad field.
Yes.
I say, well, find where your passion is. And what I loved about international health is exactly what I love about the work I'm doing now, is that you really get to know the community and you understand what the needs are, and you work with a multitude of partners to try to find solutions for the health issues that impact the community. And that's exactly what the work I was doing in Guatemala, and also went to El Salvador to do similar work, was working with the hospital partners, working with the ministries of health, working with some community organizations to then jointly find a solution to the problems. And the problem I was working on was trying to not to reduce diarrheal disease, which is a huge killer of kids under 5 around the world. And I was also working on trying to get measles and rubella immunizations, which really hadn't been done. So there were still kids being, impacted by measles, which we, again, hardly ever see, although we are seeing a number of outbreaks happening around the country with measles. So, but that, when you translate it to why local health, because it seems literally and figuratively worlds apart, it really isn't. And when you talk about the lack of resources or limitations in education or in housing and things like that, it's amazing in some ways that even though here in the United States we might feel insulated from, some of the ills that other countries that are more underdeveloped are experiencing, some of the same problems, sometimes to the same extent, sometimes not, we see just right here in our own backyard, and and some of the same solutions that they have applied in some other countries might very well be the same solutions that will work here, and some of them are. So in other countries, for example, they have really taken on the idea of a community health worker, a lay worker, a promotora, or something like that, because they don't have medical personnel. They don't have enough trained physicians, nurses, lab technicians and such. So they had to make use of the resources they had and train, to a certain extent, people who were, just people in the neighborhood, mothers and grandmothers, or, men who were interested. And so they got some minimal training. They, not even as much as, what med tech or somebody like that here would get, but just enough to do something if they see symptoms, to give them, some sort of treatment, because there's nothing else. So we've taken some of those lessons here in the United States to say, how can we apply that here, even in a resource-rich country, relatively, where we have a lot of physicians, a lot of healthcare, a lot of clinics and such. How do we apply those lessons here? And we realize that where the lesson is that it's the people of the community. Not necessarily, with some knowledge, obviously, is important, and good knowledge, but it's the trust component.
Oh, yes.
And that trust component goes so far, and way beyond what a physician or a nurse sometimes can do in certain situations. And that's not to denigrate the amazing work of our healthcare providers in the hospitals and clinics and primary care, because the work they do is really a foundation for so much of our entire healthcare system.
It's the relationship building, like you said.
It's amazing. That relationship building is so important. And when you look at the history of public health, and I like history, our health department started around 1930, and the first official health officer was Dr. French, William French, and there were other health officers before him, but there were probably, 2, 3, 4 health officers in Anne Arundel County, each serving a little region in Anne Arundel County, but Dr. French was the first one to serve the whole county. And so when you look at the work that they did, he started out with him and I think a part-time person. It was a health department of 2, and it's evolved a lot since then, and we are now a health department of about 700.
Wow!
And so we've come a long way.
Yes.
We've definitely come a long way. But a lot of the history of public health, one of the first staff was a public health nurse who would go out and do the smallpox vaccinations, go and check on kids, and things of that nature. So, but again, it's about the relationship. And I think that in public health, that's the part that we really still value in many of the programs that we continue to do today, is that relationship with the person really, I think, goes almost, it's almost 50% of the work that we do is developing the relationship, developing the trust, and maintaining the trust so that people feel comfortable and can get access to the right care.
Well, health is such a personal and invasive situation, so you almost have to have that trust and relationship building when people talk about their health. It's not like talking about, like you're saying, going to the grocery store or buying a loaf of bread, but it is very personal. Health is very personal, so to have that relationship and that trust is so vital. Now, normally we think about the health department as immunizations, basically looking at environmental concerns, water, pesticides, those types of things. But recently, we've had a crisis, not only in our own county, but nationwide. And speak to us and our audience a little bit about the opioid and heroin addiction crisis that we're facing now, that you are such an integral part of in the health department.
So when we talk about substance use disorders, first and foremost, I think it's really important for people to begin to really understand what that is as a disease. And I've been really trying to talk about it as a disease because so often what people think they know about substance use disorders or addictions is, it's been termed as, a weakness. Sort of a bodily weakness, a moral failing. Somebody is just immoral, so they choose to abuse substances. People get called really bad names. They are called druggies and junkies and addicts, and in a very pejorative way that really dehumanizes them. But ultimately, it is a medical condition in which there are some physiologic and visible brain changes over time that happens to someone who is under the influence for a prolonged period of time. And those changes are permanent. And so once someone has a substance use disorder, again, it's not a, just snap out of it, go cold turkey. It's an illness they have to deal with for the rest of their life, even somebody who's in long-term recovery for years and years and even decades. And so I talk about the language that people use to talk about the illness because I do believe very much that words matter. And so the way that we as a society and as a culture talk about something reflects our values towards those people and our attitudes and the stigma. And people talk about this stigma, but it is incredibly ingrained in our society and in our culture to look down upon people with substance use disorders, the same way that people used to look down on people with leprosy. We would rather isolate them and put them somewhere and ignore them and forget that it's even part of who we are and the fabric of, addiction is part of our culture in some ways, and certainly the people who have substance use disorders are not to be ignored. And I think what we're seeing now is that because of the sheer numbers of people with a disorder that we're seeing, that it is harder and harder to ignore. And so that's what we're certainly seeing here in Anne Arundel County as well as across the state of Maryland. In 2015, we saw 60 heroin-related deaths. And in 2016, the final numbers aren't out, but it's around 120, so we almost doubled in 2016. And so we certainly are seeing that, and it's impacting people from every walk of life. And what we believe to be some of the root causes, not all of them, but some of the root causes, certainly the prescription drug use and the way that that evolved over the 2000s, the years 2000s. Certainly has impacted the way that prescription narcotics are more available. I think there certainly have been changes made to formulations that pharmaceutical companies have tried to make to reduce the potential for abuse for those the prescription narcotics, but yet it persists. With some of those changes, the cost of prescription narcotics became higher on the black market, and so people potentially began turning to a cheaper form of narcotic, which was heroin. What has come forth in the last year, and certainly is even impacting us now in 2017, is fentanyl, and it's a synthetic narcotic. In the same family as heroin or morphine or oxycodone, but it's about 100 times more potent.
Wow.
And so a very little bit can really have the same, and we're talking about like granules of a powder versus a whole pill. It can have a similar effect such that it's impacting our law enforcement. So as they do as they intervene and they seize certain drugs, we have had and heard stories of law enforcement officers who unknowingly, as they were doing field testing, got some blown up in their face, and they were, you know, experiencing the symptoms of an overdose, and so they needed to be rescued because it's just that potent. Even some of our service animals have also experienced some of the same impacts because it is just that potent. So they've changed their practice to be a lot safer in the field and not do field testing as much because of the unknown. So, you know, a package of white powder looks the same, you know, and you don't know what it is. And that's really, I think, the issue right now with fentanyl and heroin and such, is that we talk about buyer beware, but, you know, folks with these, you know, people who have substance use disorder may purchase a product and believe that it is one thing, say if it's just heroin, but it may very well be laced with fentanyl, and they don't know that. And so they take it unknowingly, and so will overdose. And there's not as much wiggle room with fentanyl because of how potent it is. And it's not, these are not regulated by the FDA or any regulatory agency. So, you know, there's no one single formula and one concentration out there. I've seen photos from, that the DEA has shown, in which they show some of these labs that concoct these batches, and it's kind of not even as fancy as your grandmother's kitchen, where they just have a big pot and a wooden paddle and they're mixing it together. So you certainly could potentially have batches with hot spots, so fentanyl of higher concentrations, because that wooden paddle just didn't do it to mix it up thoroughly enough. So even in a single batch, there may be some variations, but that's unknown. Except when the person then overdoses. So it's really, really dangerous, you know, and so people are dying because of it. So it's important, I think, for people to understand that, you know, one, it's a disease, not a moral or, you know, personal failing, and two, that there's treatment, and treatment works. And so we're at the health department are here to work with families or other people to try to get into treatment. But treatment is not always, you know, it's there for people who want it. And so there's also that step of, you know, how do we work with people who are in the throes of their illness, and how do we get them towards seeking treatment even. So that's a very tough thing.
What partners are you working with currently as far as trying to get a handle on this and improving the quality of life for our county?
Well, you know, when I look at, you know, one of the things that we are responsible for, of course, is just looking at the entire system and how do we make sure that there are programs and services available to meet people where they are in their disease process, and families as well. And so I talk about in other settings sort of the continuum of care, and it starts with prevention. And so in prevention, we're talking about kids. So sort of going back to my roots of, you know, as a pediatrician, how do we get to younger and younger kids who are growing up in these situations in many cases, and how do we identify them and also intervene with them so to prevent that next generation of people with substance use disorders. So that's something that is very important to me. We're working with the school system, with social services, with police on this to try to get at those families. We're also doing a lot in terms of education. So, so Denial is Deadly is our media campaign, and we're working with the school system, community college, and our coalition. So we have, I think now
Healthy Anne
5.
Arundel Coalition?
Well, there's the Healthy Anne Arundel Coalition, absolutely. That's our umbrella coalition to push and promote health and wellness in Anne Arundel County. And sort of related to that are we have 5 community coalitions now that are really grassroots and regionally based, specifically trying to work against substance use within their respective regions. The one here in Annapolis is called ASAP, so it's Annapolis Substance Abuse Prevention Coalition. I love the name. The current sort of head or lead of that is Angel Trainer of Serenity Sisters. And so, but it's really trying to understand better what are the forces within a community that might contribute towards substance use or alcohol use, and alcohol I would certainly consider a substance if not used appropriately, and try to then work against it, try to work to combat those forces. So is it parental knowledge? Is it, signage? Is it advertising? So what are the things that we can work to make sure that alcohol or other substances are used appropriately or not used at all?
Right.
In terms of treatment, that's another important component of the continuum. And so our partners there are really, broad. We're working with the crisis response system, run out of the mental health agency, and of course, they're partners very closely with the police, both the Annapolis City and the county police, and all of our amazing treatment providers. We're really fortunate here in the county that we have the number of treatment providers as we do. So we have people like Samaritan House here in the city. We have Gaudenzia and Hope House and Chrysalis House up in Crownsville. Yep,
right.
all in Crownsville area. We also have Damascus House further in the northern part of the county. And they serve residents not only from this county, but from surrounding jurisdictions as well. And we have a number of outpatient providers as well throughout the county. And the really challenging thing is that it's not enough. And that's the unfortunate thing.
That is the unfortunate
So we are continuing to
situation.
work with them and as well as the state to try to build capacity and build, number of beds and number of providers and people who are trained. We work with the drug courts as well and the judges. We work in the detention center, so the health department actually runs 3 clinics. We run one here in Annapolis off of Bestgate Road. We run one in Glen Burnie, and then also at Ordnance Road Detention Center, so working with the detention facilities, and that's been incredibly successful as well. So,
but it's a huge task, and you're up to it. But we're going to ask you to give a succinct or whatever kind of message you'd like to give to the listening and viewing audience concerning the work that you're doing, or whatever you would like to tell the audience.
Okay. Well, I wanted first to thank everyone for watching and thank them for all the work that they're doing to make sure of the health and wellness of their families. I think when we talk about substance use and about this epidemic that's impacting our communities, it is something that everyone has to have a part of, and some of it is about combating the stigma. So learn more about the disease itself and the impact that it does have on an individual person. Love one another, and that seems simple, but it's hard to do. And I think that we need more treatment. We need access to treatment. If people have questions, please call the health department at 410-222-0117. Our substance use treatment referral line is available to help if anyone has any questions about how to access treatment. Resources are there. That is what we're here for. We will absolutely do our best to help people.
And we will post the website as well, and folks can go to the website to get more information. But we are so very, very blessed to have Dr. Chan as our health officer. We've had a short succession of health officers that have stepped up to the times of what we needed when we needed it. I remember Dr. Beard, definitely Fran Phillips, who was the health officer when I was employed at the health department. But thank you so much. We are so blessed again to have you at the health department and the encouraging work that you are doing. We just thank you so very much. And if people have suggestions, I'm sure Dr. Chan will be definitely looking at them and using them, and it's the trust and relationship building as she indicated.
We need everybody. Welcome all suggestions.
Absolutely. Thank you so much, Dr. Chan. Thank you for viewing and watching Watershed Moments.